Good morning, everyone. My name is Mamoon. If you don't know me, I am chairing today's session, and today is the third in a slow, I think, the series, and we have three handsome men presenting today. They'll be in soon. Let me start by acknowledging the terrible and geographic land where I have been living for last 20 years and also working here. And I also pay my respect to their ancestor, descendants, and emerging. I'd also like to acknowledge Auntie Marimanti, who is here today as well. And I would also like to acknowledge the indigenous people anywhere in Australia and globally. So we have three speakers today. Stuart Lesky is a program manager of indigenous urban indigenous centers funded by ACMRC Research Excellence. And we have Anton Clifford Motapi. Yeah, and we have also Mehdi Hassan. So all three of them presenting. I'm not going to really talk about them. I guess it's part of their presentation today as well. So storytelling they do it.
Yeah. Ready to go?
Yeah. So you can
just got to make sure I'm standing in the line.
Yeah, and
Okay, down a bit. All right, we've got people online, obviously, but I'm going to try and look at everyone in here too, because there's lots of you in here, and it's great to see. Just it's on. Not yet. On the side. Giving up the ghost. I can use mouse if you want. I'll skill, yeah. That or the enter button. So guys, I'm not sure if we have any externals in here or online, but I think everyone knows me. My role is Program Manager of the Centre of Research Excellence in Urban Indigenous Health. And I'm also a Senior Research Fellow here, as you probably know. So I just wanted to acknowledge the traditional custodians of the lands on where this CRE has been conducted. That's mainly been Yagara and Turrbal country in Yanjin, Mugunjin. Also the traditional country and traditional custodians around Australia. And just wanted to acknowledge that the Aboriginal and Torres Strait Islander people have always had traditional names for capital cities, which are displayed up there. And yeah, just acknowledge all the people from the CRE and especially the Aboriginal and Torres Strait Islander people who have been part of it. So this presentation, I'm just going to do a bit on positionality. I'm going to talk about sorry, I'm not in the screen. Background to the CRE, the Urban Aboriginal and Torres Strait Islander Health Equity Dashboard, which is a project that Fetty has led for a long time before I was at Poche, and an introduction to the Research Alliance for Urban or on Urban Community Controlled Health Services, RAUCUS, which James established before my time as well. So just in terms of some positionality, I'm a 37-year-old male, so I think I'm middle-aged, about to have a midlife crisis. He's my pronouns, upper middle class, family had 5 TVs growing up. Born in Port Perry, South Australia. It's famous for having the world's largest lead smelter. And it's Snuckino country. There was a native title claim that was successful over Port Perry in 2022. And yeah, I did spend a lot of time with that TV. So my childhood influences come from things like The Adventures of Captain Planet, Tintin, Power Rangers, and Teenage Mutant Ninja Turtles. So maybe that's why I've sort of ended up a bit left wing. And these are some photos from my childhood. So my grandpa was a school teacher and a woodworker, so he used to build a lot of wooden contraptions and tow us on his mower, and us playing in the pool at Pollara, where we went for school holidays, and also me looking pretty bewildered on a train with my sister, cousin, and grandpa. So, what is the Centre of Research Excellence? It's funded by the National Health and Medical Research Council. It's $2.5 million grant over 5 years. So that's for us 2023 to 2027. And it's a health services research grant as opposed to being public health or clinical. Just wanted to highlight that it is different from an Australian Research Council Centre of Excellence, which can be a bit confusing because we have one of those downstairs. But this is a lot smaller. So why have an urban Indigenous Centre of Research Excellence? Basically, this is Greater Capital City statistical areas in the last 3 censuses, and it's hard to see for some of the, like the ACT, but there is quite a bit of population growth everywhere, and especially, as you can see, in Greater Sydney and Greater Brisbane over time, with Aboriginal and Torres Strait Islander people. Also, in terms of burden of disease, so there's a lot of dots on this graph, sorry. Basically, we've got in orange 2018 population proportion. We've got disability adjusted life years, which is a burden of disease measure of total burden. We've got years lived with disability, non-fatal burden, and years of life lost, which is a fatal burden. So the main things to take notice of in this graph are that urban, which sometimes combines major city and inner regional, has a much bigger share of the burden of disease, regardless of what metric you look at, than say remote or very remote combined over here. And also major cities on its own still has a larger share of burden of disease than, again, remote or very remote, and other areas too. So then I know this might be a bit small for people at the back. This is a paper that was published in 2021 by some of the folks at Anala and at UQ too. So it's looking at 5 years of research outputs in Aboriginal and Torres Strait Islander health from January 2013 to January 2018. So 1,258 publications overall. And you can see you've got publications that are about urban areas only in the red dot, both urban and rural remote in the blue dot, and rural remote in the green dot. I guess the biggest one to take notice of is overall publications at the top, where we see rural and remote has the most number of publications. Then we've got both urban and rural remote, and way down here we've got urban only. And the other thing to take notice of is that pattern sort of repeats itself all the way down, with urban only papers being at the bottom, regardless of the age group you look at, study design, type of study, or recruitment site. Obviously, both urban and rural remote trades places with rural remote in some places, but generally urban only studies are at the bottom. I know mouse, don't go on me. Okay, the CRE themes. We have 4 themes in the CRE, and there's 13 studies subsumed under those 4 themes. And across those 4 themes, there's 3 cross-cutting themes applicable to every study. So theme 1, we've got innovation in Indigenous-led models of healthcare. Theme 2 is integrated healthcare systems. Theme 3 is best practice in patient-centred care and community engagement. And theme 4 is digital transformation of urban Indigenous health. And the cross-cutting themes are equity, cultural and social determinants of health, and health economics. So the CRE investigators, we have 3 from Poche, we have 5 from IUE, We've got 3 from Metro North, and then we have leading Aboriginal and Torres Strait Islander researchers, Ray Lovett from ANU, Sandra Eads from University of Melbourne, and Gail Garvey from here. And we also have 3 other researchers from UQ as well. So the Research Alliance for Urban Community Controlled Health Services, RAUCUS, was established in 2022. So as I said before my time, and it's an alliance of urban capital city ATSICs. And at the moment, we're meeting twice a year. There's one face-to-face meeting, one virtual. And the aim of RAUCUS is to drive an innovative Indigenous-led urban health services research agenda and to help us identify and set health service research priorities for the CRE. And Anton's going to talk a bit more about that in his presentation. Oh, mousy. You'll hit enter. There we go. So at the moment, the ATSICs involved in RAUCUS include all services from capital cities, except I think we're missing Ngunnawal Yunti from Adelaide, Tasmania Aboriginal Centre, and Tharawal Aboriginal Corporation, Redfern, and I think the one in Dandenong as well. So, but yeah, obviously we've got the 5 in Brisbane, and all the other capital cities as well represented. So the Urban Aboriginal and Torres Strait Islander Health Equity Dashboard, this is something we're collaborating on the AHW with, and Freddie, I think, had been working with the AHW and James obviously on this project for a couple of years before I came. So the dashboard is collating unpublished data from 2011 onwards, and the AHW are the data custodians for most of the data sets. There's also some Australian Bureau of Statistics data in there, and the data is looking at sort of demographic, health determinants, and health outcome status profiles of Aboriginal and Torres Strait Islander people. And it'll be in the typical AHW format, which is a Tableau dashboard that'll be hosted on their website. And the idea for it came from the Urban Indian Health Institute's dashboard. They're based in Seattle. So, and basically the benefit is providing disaggregated data by greater capital city statistical areas, which is sort of the functional area that people live, work and shop in, and related to a capital city. And within those GCCSAs, also statistical areas level 3 and 4. Thanks, sorry, I think we both pressed it. Did you? Thanks. So we've got a working group that meets fortnightly about this, and in that we've got Fadwa Al-Yaman, who's the head of the Indigenous group. Eleanor Bateman is the person at the AHW that we work on pretty regularly, communicate with this about pretty regularly. And then from us, there's 4 of us, so James and Stephen going to those meetings, and Fetty and I. And then we have the project management group, which has the decision-making authority over the project. And that's got the RAUCUS members in it. And so we've had members from IUE, ATSICs, Uluburi, Kambu, Zilla, Dilba, Wananga, Vars, and Ngunnawal Yunti come to that. So this is probably too small for you to see at the back there. So we've basically got the proposed measures to include in the dashboard are some stats about population size and distribution, age, sex, socioeconomic status, so exploring the feasibility of including some housing data sets, education and employment indicators, perinatal stuff from the National Perinatal Data Collection, so key maternal factors like age, antenatal care, smoking status, labour outcomes, onset of labour, method of birth, birth outcomes, birth weight, term and birth status, type 2 diabetes rates, rates of dialysis and kidney transplant, cancer incidence, survival and mortality, cause of death groups, hospitalizations by principal diagnosis, and admitted patient election status, care type, urgency of admission, median length of stay, mode of separation, and emergency department presentations. And yeah, I think most of that is AHW data. And so in terms of what it might look like, these are just some existing example dashboards that the AHW has. So we've got cancer data in Australia, general record of incidence and mortality, and this is their aged care dashboard. And these are just some screenshots we have from the AHW with some fictional data, and we're in the process of getting an Indigenous artist to do sort of a ribbon that'll go across the top and the bottom, and there'll be co-branding between UQ Poche and AHW for the website. And just in terms of where that project is at, so the project management group members will see the beta version of the dashboard first, and that'll probably occur later this year. There'll be a first public launch early next year, and then updates to the data and other aspects of the dashboard in mid-2026 and early 2028. And just in terms of CRE-related journal articles so far, so we've had sort of one that Janet Stajic has led, just about a domestically orientated paper, and then we also published one with a bit more of an international focus in the bulletin of the WHO. And that third one is a manuscript in preparation, and I'll leave Anton to talk about that one more. And I'm pretty sure everyone knows how to contact me. It'll sleep there anyway.
Are you taking questions, Stuart?
We're going to have that Q&A after the presentation.
Is it yours? Sorry.
What do I press?
remember.
Do you want me to write that for you?
Well, can I go from here? It's different to what I'm used to.
Do you want me to?
Oh. Thank you, Stuart. Thanks for the great intro to my presentation. We are experts in telling a story, and that's a phrase that actually comes from one of the Royal Commission members that we spoke to last year, and I'll talk a bit more about that later on. To begin with, obviously, I'd like to acknowledge that we're on the lands of the Turrbal and Yagara country. I'd also like to acknowledge the Indigenous lands upon which those who are dialing in are on. I'd also like to acknowledge Auntie Mary as well, here as well. So I was hoping for this whiz-bang intro, but I'm accused that I have to do it. So I won't give a whiz-bang one, I'll give a very quickly brief one. So basically, I've been at Poche now for 18 months. I started in, I think it was around February last year. Prior to working at Poche, I was working for Iui, and then prior to that, I was working at NDARC with Anthony here. He seems kind of following me around, or is it the other way around? I'm not really sure which it is. But yeah, so what I thought I'd do, just to frame where I come from, a bit about myself, so my family and cultural background. So this woman on the left is who I call mum, and she's the woman who actually raised me. So I was adopted into a family of 10, one of 10, and so she had 9 siblings, naturally, and then for some reason, chose to adopt me at number 5. I'm not too sure why. And she's from the area here, which is, where is it? Can't even read that. Himalaroy country, sorry. And so she's just from around Lightning Ridge, and she's an elder out in the Moreton Bay region. She's lived there for about 75 years. She's now 82, and does lots of work out there. If you ever happen to be in a meeting with her around health, don't use acronyms because she hates them. And she'll put her hand up and say, can you speak English or speak properly? Which I find quite amusing, because as kids, she would always shorten our name. So Anton would be Ant, Andrew would be Andy, Fiona would be Yoni, and yet she hates acronyms. So that's where I was raised, and I grew up in Redcliffe as well. But in terms of my cultural heritage, so on the right there is where I'm from, which is Lesotho, which is a landlocked country in the southern part of South Africa. And my father is there, who was on the left. He's the far left there. And that was taken some years ago now. And I also have family in South Africa, Lesotho, and also Botswana as well. Okay, and I met my father when I was about 30 years of age. Okay, and Stuart, you said you're middle-aged. So if you're middle-aged, I don't want you to think about what I am. Honestly, man. And yeah, anyway, I think as you get older, like your middle-aged age sort of pushes up as you get older. Okay, so that's sort of me in a nutshell. So the aim of this research, like I said, was to really find out what Raucous members want to research and what they want to have in a Poche research agenda. And so we spoke with 10 Raucous members. We did in-depth individual interviews with them, 6 Indigenous and 4 non-Indigenous, 2 each from the services in Perth, Brisbane, Ipswich, Darwin, and 1 each from Canberra and Sydney. We didn't get to interview anyone from VARS, but they were a part of a working group that we met with afterwards. So in terms of the methods of the interviews, so we analysed interviews by themes using a system of open and axial coding. We have this coding framework here, which I talked through with Janet and Stuart, and they kind of helped me just sort of understand, I guess, what was kind of going on. Stuart in the context of the urban CRE and some of the stuff that he showed, and obviously Janet from the perspective of someone Indigenous. And if you have a look at the, I guess there were 4 kind of, those 4 arms which kind of come out there represent 4 very broad themes in terms of how the Raucous members told their story. And so they talked about their role in the service, or their role in the actual story. They talked about gaps in the story in terms of like gaps in health, Aboriginal health and Torres Strait Islander health. And they talked about how they wanted that story told as well. And by story, I mean how they wanted research done, basically. And so once we move from that then to sort of, I guess, a presentation of prelim themes at the working group meeting, so at the workshop at the annual Raucous meeting, which was held in August of last year. And there were 12 Raucous there and 5 Poche staff. And we kind of talked through what those actual themes were. And then I was able to go away and I guess spend some time and revise some of those themes. So what I'll talk through now is what those themes are. And these are the themes Stuart talked about, a paper, and these are the themes that are in that manuscript. So these are the priorities of Raucous members. So the first one is they talked about a real need to improve the effectiveness and the efficiency of models of care within AICS services. And one of the key things that they felt was that if you looked at the urban AICS services, they felt that the actual model of care hadn't actually changed much since the origins of AICS in around 1972. And so what had happened, and Stuart talked about the actual growth in like client numbers and things like that, and the changing profile of our clients as well. And so they just can't keep pace with that. And so what they're looking for is more kind of adaptable, flexible models of care that can actually keep up with that growth and that change. They also talked about how do we build a responsive AICS workforce. So given all of this growth and change, what is the optimal mix of the workforce, whether that be GPs, health workers, nurses, whatever? What is that optimal mix? And if you think about, say, ISOC 2 and the work which is going on there with IUE, that is really around trying to find that optimal mix of the workforce. So it's the workers you have, but it's also how those workers actually work together as well. And so I guess what that pod model is trying to do is shift a focus of clients being kind of GP centric to being attached more to a team of workers. And then also the other thing that came about was how do we measure the activities that occur at the health worker client encounter? And by health worker, I mean Aboriginal health worker, nurse, GP. And so there's a lot of work that happens in AICS that obviously is captured through their IT systems, but there's a lot that is hard to capture. And they're sort of saying, well, can we audit that in some way and capture that to really show what our actual value is? And there's just some quotes down there. I won't read those. So that was the first one. And these are in no particular order either. So the second priority was around strengthening care pathways and access to specialist services. So they spoke about a range of barriers to accessing services. Things like long waiting lists for early childhood services, a lack of AOD services, so a whole range of things, barriers. But what they also said is we really don't know how they kind of interact. And we don't know, is it that the services aren't there? Is it that the services are culturally unsafe? Is it that the clients don't actually know about these services? Or is it that the services are hard to reach? And often we talk about hard to reach clients, when in fact it's actually hard to reach services. And they really wanted to co-design systems of care that actually support clients when they're accessing and also leaving specialist services. And that's really about how do you link those range of health and social services so a client can move through those services from like one to the next and back and forth. And then they were also interested in the role of virtual healthcare as well. So things such as telehealth, phone apps, etc. And I think one of the things, as you were talking there earlier, Stuart, as I noticed, is that those themes of the actual CRE are closely aligned with these. And I think those themes came about, I think they would have been prior to this work as well. So it's good to know that there's actually that match there. Alignment. And then the third priority, which I thought was interesting, was examining the intersection of Aboriginal and Torres Strait Islander identity, racism and cultural stereotypes and their impact on health and well-being. And this was very prominent amongst, I guess, Aboriginal Raucous members who really spoke and expressed a strong view about, just check my notes here. So they're really kind of highlighting two things. One is, and there were two kind of, I guess, two assumptions. So one was that if you're urban and you have fair skin, that you actually are privileged. And the second assumption was that if you are urban and have light skin, is that you can access mainstream healthcare and you don't actually experience any kind of racism at all. And these are things that they're kind of grappling with, and some of the clients are also grappling with as well. So what they want to do is unpack and try to work out what is the impact that has on someone's health and well-being. And then they also wanted to build an Indigenous-led evidence base around how do we strengthen cultural identity to improve healthcare and also improve healthcare outcomes as well. So the fourth priority was really more about how they want to be doing research. So those kind of three things I spoke about earlier, this is the how. How do we want to be doing this? And this is what we feel needs to happen. So one of the things they spoke about was they said that quite often what happens when they get asked to be involved in some kind of project is the funding is there, but it's there to fund a job just that lasts the actual length of the project, and that's it, and then it's gone. And that actually impacts upon how they can actually engage in research. So what they really want to do is shift that focus and shift that investment to funding that actually builds expertise and skills within an AICS service. And some of the ideas they put forward, which I thought were quite interesting, were around, allocating a minimum amount of a budget to build research skills and expertise in AICS. Now that could be something that obviously comes down from like NHMRC or someone like that. But if not, Poche could have that as kind of, a guideline around that. And data sovereignty as well was also considered extremely important, and obviously around ownership of what they actually collect as well. And one of the things they wanted to do was, again, this kind of relates to the AICS and the way in which they, I guess, kind of offer care, was that they wanted to try to find ideal IT systems to actually capture what it is that they actually do. So I think if you look at AICS services, you'll find a whole range of, IT system or PIMs used across like all the services. I can think of at least about 4. So is there an optimal IT system out there that can actually capture what AICS do? And we've actually spoken about this in terms of resi rehabs and stuff like that. But if you look at again by UE, I think they're sort of an example of an AICS that actually built their system to capture what they do. So it's not that they retrofit what they do into that system; they build the system around what it is, what their actual core work is. And then the final thing, which I thought was interesting, obviously co-design research is how they want to work with researchers, but the meaning of this varied a lot. From people who felt it was, well, we approach a researcher or a centre and tell them what it is we actually want to do, and they go away and they work it up and bring it back. That was like, one example. To the other example, which was where you come to us and we show you and tell you what it is we actually need and want to do, and actually how you'll do it as well. And I think all of the literature, it also kind of speaks to that as well, how it's quite a contested term. And I think, Anthony, you had a paper which kind of speaks to that as well, around what is the actual meaning of it, co-design research. And again, I think that's an area where I guess, Poche can kind of lead that work as well. What do we see it as, in our work? And that is it. So those are the 4 main areas. I think I stuck to time. Did I? And these are just 2 references, and then that's me. Thanks.
Morning, everyone, and welcome again to the Poche Research Highlights Seminar. My name is Mohammad Mehdi Hassan, and I am a postdoctoral research fellow here at EQ Poche Center. So today I'm going to present about myself, actually, including my education, employment, and engagement in public health research, mostly focusing on advancing health of these advantaged populations. And so, my today's presentation title is Bridging the Gaps, Path from Education to Contribution in Advancing Health Equity for Disadvantaged Communities. So before going to my presentation in detail, I'd like to express my heartiest gratitude and respect to the indigenous population living all over the world, and especially to those who are living in Australia and sitting here at Poche Center. And the University of Queensland acknowledges the traditional owners and their custodianship of the lands on which we meet. We pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to the country. And we recognize their valuable contributions to the Australian and global society. So here I am working with a very vibrant team of life course epidemiology under the brilliant leadership of my gorgeous and dynamic supervisor, Professor and my lovely colleague, Dr. Shanja and Dr. Edmund, who are serving here as a research fellow, me as a postdoctoral research fellow, and also Tilini as a research assistant, but who is going to be a doctor very soon, and best wishes for your Tilini. And also we have two very young and energetic doctoral researchers, Mr. Ashraful and Ms. Lim. So I believe that together we are very strong and has a potential to make a positive impact to the community with our cutting edge research. So here is a very short brief about my presentation today. So today I will deliver very briefly about my education, my demography, education, employment, engagement, partnerships, projects, contributions, and future plan. So I could born in a very remote and rural areas of Somalia and could face some severe starvation of foods and livelihoods. Or I could born in the family of Bill Gates and donate for them. But fortunately or unfortunately, I born in a developing country like Bangladesh. And more specifically, it's not working.
Wasn't my board as well. Yes.
And more specifically in Kustia, which is the 13th largest city of Bangladesh, with full of diversity in terms of culture, religious beliefs, and social structure. So being born in a developing country, I have heard our mothers dying. I have seen our kids dying due to avoidable causes. The moment I'm talking here in this seminar today, at the same time, our mothers are dying in low and middle income countries. Our kids are dying in low and middle income countries. So this has led me to build my research career in maternal and child health research.
Enter.
Okay. So let me introduce very briefly about my educational background. So in 2009, I did my bachelor from the Department of Statistics, Biostatistics and Informatics from the University of Dhaka, which is one of the oldest universities of our country. And also I did my master degree from the same department of the same university in 2010. And I also achieved a Master of Public Health degree from Othish Dipankar University of Science and Technology back in 2014 with a solid CGPA of 4 out of 4. But this was not the end of my journey, actually. So I enrolled in my doctoral research under the supervision of Professor Abdullah Mamun here at UQ. And fortunately, I was able to complete my doctoral degree in early January 2022. I was fortunate because some of you may know, but mostly may don't know that I had to move to my home country during the COVID period. I was stuck there and was not able to return back to Australia and to continue my study. But I'm really, really grateful to the University of Queensland and particularly to my lovely supervisor who allowed me to continue my work from there and complete my study. So I'm really thankful to you, sir. I started my professional career back in 2012 with the International Center for Diarrheal Disease Research, Bangladesh, as a statistical officer during 2012 and 2013. ICTW is a globally renowned international research organization based in Bangladesh and has contributing a lot in global health research. And some of us may know about ICTDRB. So I had the opportunity to start my professional career with ACT Derby, and after a 1-year journey with ACT Derby, I joined Helen Keller International in a bigger position with greater responsibilities and served Helen Keller International from 2013 to 2017, holding several early to mid-level positions before coming to Australia for my PhD. And during my stay in Australia at UQ, I was able to do some research work with several schools of UQ as a research assistant, particularly during the time 2018 to 2020, before I moved to my home country. And then after completing my PhD, I joined again to Helen Keller International as a research fellow and served as a deputy technical coordinator during the period 2021 and 2022. And then I moved to ICTW again and joined there as a senior research investigator and served there for nearly 2 years during 2022 to 2024 with an aim to engage myself more broadly in public health research, particularly focusing on maternal and child health research. And after 2 years of extensive service at ICTW, I was blessed again by my supervisor who offered me to join with his team as a postdoctoral research fellow. And that is why today I am here and presenting in front of you. So during my professional tenure, actually, I had to move sometimes clockwise and sometimes anti-clockwise. So during my professional and academic tenure, I was able to build some engagements with some academic institutions and also some professional networks across the world. And as part of this, I am a member of Life Course Center of the EQ as an academic member, and also I am a professional member of the global research communities, including the Global Burden of Diseases, American Society for Nutrition, International Health Economics Association, Health Systems Global, and also Society for Research in Child Development. I was also able to establish some partnerships with some government and non-government organizations in my home country, and also trying to build this relationship here in Australia and across the world. So in my home country, I was able to build partnerships with the Directorate General of Health Services, Bangladesh Bureau of Statistics, and Bangladesh National Nutrition Council, while implementing several projects with these government bodies. And apart from this, I established some professional relationship with some other non-government organizations, including International Food Policy Research Institutions and also Save the Children. And apart from this, I led and engaged in a couple of research projects with the Bangabandhu Sheikh Mujib Medical University, which is the only medical university in our home country, and also with the University of Dhaka and North-South University. So here at UQ, I am engaged in a couple of projects that are mostly related to some close collaboration with the government bodies and particularly the Queensland Health. So as part of this project activities, I am trying to establish this sort of a professional relationship with the Queensland Health. And also I'm in a process of establishing and expanding this professional network across Queensland, including the George Institute at New South Wales, and also the University of New South Wales, with an aim to apply for big collaborative research grants in near future. And also, I established a proven track record of partnerships with the Life Course Center and the James Cook University by publishing some high quality, good products. And this has helped me to establish this professional relationship with these institutions. And apart from this, I was engaged in a couple of works and produced some outputs with the academicians who are working in the Johns Hopkins University in the United States, University of Gothenburg and Uppsala University in the Sweden, Bangor University in the UK, and the University of Bristol in the UK. And I'm still trying to expand this professional network in Australia and across the overseas so that I can establish my career in global health research. So here are some projects that I was engaged during my professional tenure. So as I mentioned before that, I started my professional career with ICDDRB. I engaged with 2 projects, including the maternal and young child nutrition security initiatives in Asia, McKinsey in short, and also an impact of NGO training and support intervention on private sector provider for diarrhea management practices. And during my stay with Helen Keller International during 2013 to 2017, I was engaged in 4 projects, including the Food Security Nutritional Surveillance Project, Reducing Malnutrition through Farmer Nutrition School Project, Evaluating Women's Empowerment in Agricultural Index Project, and also Enhancing Food Security and Nutrition Project. And during my stay here in Australia and served as a research assistant here at UQ, I worked on a couple of projects, including antibiotic use and genetic risk in livestock production in India, deferring living and returning to university studies in Australia with the ISSR, COVID-19 work and family transitions project with ISSR, assessing infant and young child feeding practices and the role of maternal education in IOSF practices in South Asian countries. So I was the co-investigator of this project with ICDDRB. And also I engaged in other projects, including Sleep for Strong Souls that is leading by Associate Professor Fatima. Then when I returned back to Helen Keller again as a research fellow, I was the deputy technical coordinator of the National Information Platform for Nutrition Project and highly engaged with the government of Bangladesh, particularly the Bangladesh Bureau of Statistics and other multi-sectors in executing this project and establishing the nutrition platform in our home country. And also I engaged in other 2 projects, including enhancing homestead food production for improved nutrition, health, and livelihood, and reduced child marriage, and also improving health-seeking behavior for diabetic retinopathy. And then as a senior research investigator at ICDRB, I was engaged in a big project in advancing sexual and reproductive health and rights funded by the Global Affairs Canada. And I played a role of deputy project coordinator of this project. And also I had some 2 PIC projects at ICDRB, including the advancing the monitoring of pregnancy-related diseases and conditions among first-time pregnant women in rural Bangladesh, and also advancing the register system for managing infertility, high-risk pregnancy, and obstetric fistula in Bangladesh. I was the focal point of other 4 projects as a co-principal investigator, and this includes the advancing the understanding of pregnancy-related diseases, conditions, and complications among first-time pregnant women in rural Bangladesh, in short, at prediction. So this is a prospective cohort study. And also advancing the management of maternal and newborn health services at selected Upazila health complexes based on national guidelines and global standards. So this was an implementation research where I was leading the project as a co-principal investigator. And also I engaged in an assessment of sexual and reproductive health among women of forcibly displaced Myanmar nationals in Cox's Bazar, and assessing the feasibility and effectiveness of introducing midwifery-led community clinic model into the health systems of Bangladesh. I was also engaged in other 3 projects as a co-investigator at ICDRB, and these include the development and testing of an app, and this is an electric platform to promote peer communication and facilitate digital capacity building activities under the government's school-based health program. And also ICDRB, I know this is also a digital app-based project, particularly focusing on a one-stop initiative to create a gender-friendly environment and promote knowledge exchange. And finally, the research prioritization of sexual and reproductive health and rights to enhance policy, program, and practice in Bangladesh. And now here at UCO as a postdoctoral research fellow, I am working with my supervisor in 2 projects and particularly focusing on the exposure to trihalomethanes in pregnancy and birth outcomes in Queensland from an integrated data, and also assessing the perinatal outcomes among indigenous and non-indigenous Australians. This is also driven from an integrated data analysis of linked data. So here is a brief description of the objectives of these 2 projects. So in the trihalomethane projects, we are exploring the association of exposure of trihalomethanes during pregnancy with the low birth weight, preterm birth, small for gestational age, stillbirth, and perinatal mortality. And apart from this, we believe that sometimes Professor James may wish to design a study for a waterborne diseases and may like to know the areas with high vulnerability of trihalomethane concentration. Professor Anthony may be interested to design some health service research. Professor Fedi may be interested to design some large clinical trial research. Professor Mamun could be interested to design some implementation research based on the preterm birth, low birth weight, and they may be interested to the areas with high burden of these outcomes. So keeping this all in mind, we are also exploring the geographical distribution of the trihalomethane across the local government areas in Queensland, and also the distribution of low birth weight, preterm birth, small for gestational ages, etc., across the geographical areas in Queensland to better understand the high burden locations of these outcomes. And in the closing the gap projects, we are exploring the burden, trends, and factors of perinatal outcomes among indigenous and non-indigenous Australians living in Queensland. We are also examining the trends and projections of healthy birth weight among indigenous and non-indigenous Australians living in Queensland. We are also examining the inequalities in perinatal outcomes, including low birth weight, preterm birth, small for gestational age, etc., in terms of the economy, education, and other identity that are matched with the inequality dimensions. And also, we are exploring the maternal model of healthcare for the indigenous and non-indigenous Australians living in Queensland and their association with the perinatal outcomes. And finally, we are planning to examine the impact of COVID-19 on perinatal outcomes and how this COVID-19 impact the indigenous communities and as well as the non-indigenous communities. So from the trihalomethane project, we are developing the first 3 manuscripts based on low birth weight, preterm birth, and HGS. So this is under progress. And also we are waiting for the approval for the data access. And as soon as we have the data, we'll go for the final analysis and finalize the manuscript for journal submission. And for the closing the gap project, we are in process of submitting the ethics application, and hopefully we'll be done with the ethics application and receiving the data access very shortly. So here are some snapshots about my contribution based on my education and employment so far. And I was able to contribute to advance the health equity by publishing 46 journal articles and publishing more than 15 research studies in media, 12 research reports, 5 conference presentations, and 1 book chapter. Apart from this, I was lucky enough to develop 10 policy briefs, and among these 10 policy briefs, 2 were taken for action by the government of Bangladesh and also a non-government organization in our home country, namely Smiling Sun, for improved nutrition. And also, I'm serving 9 international peer-reviewed journals as a reviewer. So I believe that I'm not meritorious, but I personally believe that I'm a laborious guy, and that's why I'm an ambitious. And I made a very ambitious plan what I want to see me at the later stage of my career. So as part of this, I have set some plans that I need to do and execute, and this includes the advancing the engagement with the indigenous communities to have a better understanding about the indigenous health. And also I have a plan to start supervision of higher degree research students from 2025. And more importantly, I am planning to explore the opportunities for the fellowship applications and have a plan to apply at least couple of fellowship applications in next a couple of years. And same thing applies for the research grants. I have a plan to develop some research studies, conceptualize this, develop and submit at least couple of research grants in next 3 to 5 years. And also I have an ambitious plan as well. So I have a plan to secure at least 2 research grants in next 5 years and 5 grants in next 10 years. And based on this, if I can do this, I can expect some promotion of level B in 1 year. I can expect promotion in 5 years, level D in 10 years, but at least in level E before my retirement. So there's no timeline for that. And finally, I want to be a leader in health equity research, not only in Australia, but also in global context, with the aim of advancing the health equity for the disadvantaged living all around the world through my education, employment, and enthusiasm. So that's all from my side. Thank you for patience hearing.
Thank you all. We have a few minutes for questions. I think Andy,
that opportunity is gone. I'm old, yeah, but you're amazing, you fellas, eh? Right? What the heck? When do you learn to breathe? Hey? Oh, I don't have a track record like that. It's more footprint. Hey, but it's a difference, but certainly acknowledging that, yeah, no, I won't trouble you, Stuart. I don't, I'll get you later.
I'll try.
Yeah, but I think it's exciting to listen to what, you know, people sitting next to you or, you know, across the table or wherever is up to. And I see you walking around and I don't see that. Right? So for me, it is hearing what you do. And then I guess that's maybe it's an old person's thing, or maybe it's just a me thing.
Middle age, Auntie Mary.
Pardon?
Middle age.
Yeah, yeah. These two saw themselves as the lower level of middle age.
well,
You in.
I'm quite a bit older than Stuart, so I was just laughing at his notion of what middle age is.
See, if you saw yourself like that, would you probably, what's that from middle age?
Let's not talk about
No, I was just curious how you present the information, and it is about the artist, it's about the story. Hey, the story that you've been involved in and sharing it. Sometimes not easy because you've got to capture the, look, I don't think anybody's left the room, but we can't move here because when one person does, the chair does. It's capturing the mind and the mindset around giving you a yarn and making those connections and being interested too. I think it's about being interested in the work that you do. So very good. Well done. And amazing.
Thank you.
No questions.
Any questions from anybody?
I had a question for Mahidi. if I
Yes.
could. Can you tell us a little bit about the indigenous populations in Bangladesh? Do they face some of the same health equity issues as our communities here in Australia?
Yeah, during my professional tenure with Helen Keller International, I had the opportunity to work in some hill track areas where some of the ethnic communities are living actually. So yes, there are some issues of equity gaps between the ethnic populations and the non-ethnic populations as well.
Yeah.
And this actually mostly driven by their geographical locations actually, particularly for the hillside areas. It is very difficult for them to reach to the facilities, for example, for seeking healthcare from the government facilities or even the private facilities. So of course there are some issues in equity gaps in terms of health and health services between the indigenous or ethnic or non-ethnic communities in our home country.
Yes, it's pretty much similar.
Is it?
everywhere.
Right.
Yeah.
Yeah.
Pretty questions online.
Questions online, yeah.
No question. Anybody from online, please? One last question.
Maybe a question about the study that you did on midwifery-led community clinics and the feasibility. So as I mentioned a few weeks ago, I was involved in evaluating the midwifery education. So I'm just, interested to see where it's got up to now.
Actually, it was this was an implementation research that we were conducting in a rural setting of Bangladesh, where there are a couple of community clinics there. So in our country, the CACP is the lead of the community clinic. But apart from the CACP, we are planning to introduce the midwifery at the community clinic level to ensure some basic maternal health services at the community level, particularly for those who are living in far from the urban or peripheral urban areas, so that at least they can have some care during their antenatal period. In most cases, what we found that most of the mothers are not willing to come to the health facilities, and particularly because of their transportation issues. So if we can make this service available, ready to their closed door, then we believe that it could help them get the services during the antenatal period at least. So keeping this in mind, we designed a study by introducing a midwife at the community clinic level and see how is this feasible to introduce this midwife cadre in the existing health system, in the rural health system in Bangladesh, and how this midwifery care is effective in increasing the number of antenatal cares, and also in the long term reducing the pregnancy complications and maternal and child mortality.
Be interesting to look at the urban areas as well, though, right? Because my PhD was based in Thailand, which looked at maternal mortality and mortality, but what Thailand has seen is the over medicalisation of birth and the lack of midwifery availability. So midwifery, we know goes way, way back, but that's been taken away from a lot of communities, and so there's common themes. Just trying to reclaim midwifery back for women and families. Yeah.
Okay. Thank you. I think we are a little bit over the time. Thank you all, and please give a big round of applause.